All right, good afternoon, everyone on the East Coast, at least. It's Brandon with the National Minority Quality Forum. Just excited to have a good conversation today on prostate cancer. And then also want to get to welcome back Mia. She's been doing a whole bunch of stuff, but we're so glad and fortunate that she's back, and she's going to be moderating today's very special panel with Doctors Hall and Bullock from the Show Me State, and they're going to show us the work that on the prostate cancer space. So without further ado, I'm going to turn it over to Mia.
I love the introduction, Brandon. I'm very glad to be back with the NMQF family, and especially with our audience, and certainly with our esteemed guests today. Many of you, I think, will find today's conversation to be really quite familiar, and I look forward to having not just a conversation from a scientific perspective and from a community outreach perspective, as both of our leaders today are able to speak to those, but we might get a little personal, and I hope that we have room for that. So without further ado, as Brandon mentioned, I want to just briefly introduce our guests today. So first we have joining us Dr. Lannis Hall, who serves as the Director of Radiation Oncology at the Siteman Cancer Center at Barnes Jewish St. Peter's Hospital, where she's also an Associate Professor of Clinical Radiation Oncology at the Washington University School of Medicine. And Dr. Hall is also the founder of the Prostate Cancer Coalition, which is a group of healthcare providers and prostate cancer survivors, as well as community organizational representatives who are all dedicated to raising awareness about prostate cancer, particularly amongst high-risk men, and especially, I imagine, African-American men, and we'll be talking about that. And in that capacity, she's developed the first prostate brachytherapy program in St. Charles County, and she's performed over 1,100 procedures. And she also is quite the media brain in that she hosts the Prostate Cancer Question and Answer Show, which is a podcast series broadcasted on Gospel 1600, and it's also available at iHeartRadio and iTunes. And I'd be remiss if I didn't also mention that Dr. Hall is the mother to two young adults, Eric and Ella. We're both working in international affairs and also in politics. So thank you so much, Dr. Hall, for joining us today. And you, of course, are joined by your, well, I don't know if you know that you're joined by a background guest, my dog barking in the background, but I'll speak to him in just a bit. But you're also joined today by Dr. Arnold Bullock, who is your colleague over at the Siteman Center, and where he serves as the Alan A. and Edith L. Wolf Distinguished Professor of Urology, also Washington University School of Medicine. And he also serves as the Director of Men's Health. Dr. Bullock, in addition to being a full academic urologist at Barnes Jewish Hospital, he's also a proud graduate of Xavier University of Louisiana, and he also received his med degree not too far from my stomping grounds. I'm in DC, but he attended down the street in Baltimore at Hopkins University School of Medicine. And he too is also a native of the DC area and married for 30 years to 3 adult children. He also enjoys carpentry, golf, and piloting small planes. So if ever the world is coming to an end, I'm going to call you so that I can get on your plane and you can build all the things and get us on out of here. So without further ado, Dr. Bullock, I'm going to turn it over to you. So you're going to share with us just a bit of words and in presentation form, and then we're going to segue into some words from Dr. Hall, and then we're going to have a conversation all together.
Well, thank you very much. Dr. Hall and I appreciate this opportunity to present on this major health crisis, and we need your support towards improving this grave disparity in prostate cancer and to overall improve the morbidity from this disease. We had some challenges this morning with getting my slides to come up. So am I going to do it, or is someone going to run the slide sets for us?
I believe Keiko is going to assist.
Okay.
Yes.
And by the way, to our audience members, as always, if you have questions and comments, please put your comments in the chat box and your questions down below. I can access your questions a lot faster when they're in the Q&A box, but keep the conversation rolling amongst yourselves in the chat box. And I think we're ready for you, Dr. Bullock.
Okay, great. Well, what we're talking about today is this racial disparity in prostate cancer. And we would like to go through some of the benefits of screening and early treatment. I'm going to do the first portion of our presentation, followed by my colleague, Dr. Lannis Hall. Next slide. So overall, prostate cancer is just the poster child for this disparity in cancer incidence and mortality overall between Blacks and whites in the United States. Next slide. we have a higher incidence and mortality. The Centers of Disease Control tell us that African-American men die of prostate cancer on average 7 years sooner than white men, and African-American women die 4.3 years sooner than white women. So this excessive death rate from prostate cancer is what we're trying to address. Next slide. If we look at prostate cancer represents 1/3 of all cancers diagnosed in American men. There are 248,000 men who are diagnosed with prostate cancer in the United States here annually. It represents 9% of cancer deaths, only behind lung cancer. And the annual mortality rate from prostate cancer of 33,000 US men is equivalent to that of women who die from breast cancer here in the United States, percentage-wise. If that's not bad enough, you can look at the disproportionate suffrage of African Americans, that we have a 70% higher incidence, and I'm 2.4 times at greater risk of dying from prostate cancer than my white colleagues. So these are the issues that we're trying to address, and we think is a grave medical problem that needs to be addressed. Next slide. So this slide is a slide I made based on the data from the American Cancer Society back in 1984. 1984 was picked because the PSA really was developed in 1984 and initially put into some type of preliminary clinical trials. But if you see here, this is back when we used stage A, B, C, D for prostate cancer. So stage A is one that you can't really palpate. B is a palpable disease localized to the prostate. C means there's some local, locally advanced disease. And D is cancer that's spread metastatically, either to your bones or your lung. So at the time of diagnosis in 1984, a white American had a 38% chance of already having metastatic disease. But Blacks had a 2/3 chance of already having metastatic disease if you look at the C and D stage of cancer. Next slide. At Washington University, where we are based, we've had one of the largest prostate cancer screening studies in the country. They were run by Dr. Catalona. Now, if you look at the data from just 12 years later, post-PSA, this represents men who almost all of them had at least one prior PSA screen. So if men participate in PSA screening, their chances on subsequent follow-up of having advanced disease in the whites, there was none. In Blacks, it was 17%. Oh, 17%, that's terrible. Well, it's a lot better than the 65% that we had 10 years earlier. So we can use PSA for the early detection of prostate cancer. Next slide. So this is a slide on rectal exams. There was a question by one of the respondents, should we still use rectal exam? I certainly do, because this study from 2007 shows that you can still pick up rectal cancer in 13% of men who have a normal PSA. And 20% of cancers picked up by DRE alone are either non-organ confined or of a higher grade. Next slide. So if you look at the years in which PSA came into effect, the late 1980s, you see this surge in incidence or diagnosis of prostate cancer. In the whites, you go from around 120 per 100,000 up to a surge of around 240 per 100,000. But of course, after first pass PSA testing, the rate of cancer incidence drops down to our present level. But even before PSA, you see how much more African Americans are affected. You have this huge peak in incidence, but also look at how the rate of mortality rate has dropped in all races, including Blacks. And so over the last 25 years, we've had a 50% reduction in prostate cancer death, even in African Americans. Next slide. So our mortality rate at present still has a long way to go. And part of it is related to the rate of having distant disease at the time of diagnosis. This slide shows that for most of the age groups, African Americans still present with distant disease at 3 times the rate of whites. Next slide. It's also true that some of our outcome is destined to be worse because we tend to have higher grade disease, more aggressive prostate cancer at the time we're diagnosed. So even using post-PSA era, you see that African Americans at all age groups are more likely to have at least in 7 to 10, or the more aggressive prostate cancer as compared to our European American counterparts. Next slide. So, but despite all of that, you can see that our 5-year survival now for localized and even regional disease is 99%. So some of this is not just based on can we pick people up at an early stage. Some of this must be due to improved treatments, because we've gone from 62% 5-year survival to 99%, and that with localized disease, that must be accountable for improvements in how we treat. But even today, 30 years later, if you're diagnosed with metastatic disease or distant disease, your 5-year survival is still only 30%. Next slide. So again, if we wanted to just look at drops in mortality rate, because that's how we're judged. If you look at 1992, 1993, when the PSA was approved, you see a steady drop in mortality rates using the worst group, the African Americans at the top, year by year, bam, 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 bam. It just keeps falling up until 2012. So that's a 2% per year decline in mortality rate in Blacks. Next slide. So up until this point, everything sounds gravy, right? We came up with this test. We can pick up prostate cancer at an earlier stage. We're dropping the mortality rate. And then of course, the bomb blows up. The bomb is the U.S. Preventive Task Force. The U.S. Preventive Task Force is shown here, New York Times, 2011. Healthy men should no longer receive PSA blood tests to screen for prostate cancer because the test does not save lives overall. What do you mean? We just showed these slides. It shows that it does. And it often leads to more tests and treatments that needlessly cause pain, impotence, and incontinence. So let's talk about that. Next slide. So this is based on, so some of these slides were actually to be erased. It's based on the European randomized study of screening for prostate cancer. Next slide. And it's also, that's a European trial, and it's also based on an American trial, the prostate, lung, colorectal, and ovarian trials, which we'll talk about next. But the European trial had 162 men who were randomized to PSA screening every 2 to 4 years versus no screening. Men was followed for 13 years. There were 42% more cancers diagnosed in the screen group versus the control group. At 13 years, there was a 21% reduction in death. It required 700 men to be screened for every life saved, and 29 men diagnosed for every life saved. So that's a criticism. You have to screen 700 men to save 1 life. But this same group, U.S. Preventive Task Force, reported that it takes 1,250 women to be screened to prevent 1 breast cancer. So prostate cancer, this is not unusual. It's the same for colorectal, breast, that you have to screen a lot of people in order to save 1 life. Next slide. So in the end, the ERSPC trial showed that screening does identify more low-risk cancers, more organ-confined cancers, and most in the control group had not been screened. This was truly a screened versus not screened population. The criticism was that it was conducted in 8 European countries with a very low population, of course, of men of African descent. Some might say that this, along with the fact that you're only screening every 2 to 4 years, if you were to include people of African descent at a higher risk, your rate of picking up prostate cancer by screening might have been even better. The number of lives saved might have been better. But again, there's a problem with studies where people aren't adequately represented in clinical trials. Next slide. So if you look at the bottom line, 299 men died in the screening group, 462 men died in the control group. Statistically significant improvement in overall death rate. Next slide. If we look at the PLCO study, and you might notice Dr. Gerald Andrew, that's my boss here at Washington University, so I don't want to say anything too bad, but it was a bad study. So the problem with this study that was completed in the same time frame, next slide, is that this study had 76,700 men. They were randomized to annual PSA screening and digital rectal exam versus usual care by primary physician. This study started 1993. This is at the heyday of PSA being available. Biopsy was recommended for men with a PSA greater than 4. They only found 22% more cancers in the screen group versus the control group, but there was no difference in mortality at 7 years. This was the basis for the U.S. Preventive Task Force saying there was no need to screen then if we can't see an improvement in death rates. New paragraph, new slide. So the problem is that 52% of the control group admitted to having a PSA being done during the study. But we also know now that 85% of the people on both sides of the study had a PSA either before study entry or during the study. And so it really wasn't comparing a screen group versus a not screened group. Essentially, 85% of them had been screened. The other major flaw is that there was only 4% participation of African Americans in a study done here in the United States. So it's inadequate for statistical analysis of the highest risk group. Next slide. So when you look here, in fact, the screening group had a higher death rate of 158 men as compared to the control group. Not statistically significant, but it just shows that there was no difference between these two arms. Next slide. So fortunately, with enough outcry and rebuttal, the U.S. Preventive Task Force came out with a change or a variance in their screening recommendation in 2017. But we don't agree with this because it suggests that men aged 55 to 69 should have informed decision about the benefits of screening with their primary care. But this ignores the fact that African American men develop prostate cancer at an earlier age. And we recommend that men get their first PSA at between 40 or 45 if they're African American or have a family history of prostate cancer, i.e. if they're in a high-risk group. Next slide. So criticisms of prostate cancer screening as I close. Screening does not save lives. Well, we've shown that you can save lives by having cancer detected at an earlier stage. And those cancers detected at an earlier stage have a very high 5-10-year survival rate. So the prostate cancer mortality has fallen by nearly 50% in African American men. Too many biopsies for every diagnosis. That's true. Based on PSA and DRE alone, you'd have to biopsy 5 men to pick up 1 man with cancer. But we now have a whole host of biomarkers, PCA3, 4K, in addition to 3T MRIs that increases our sensitivity, and we should be able to decrease dramatically the number of men who need a biopsy because the sensitivity is up to 80% with these newer modalities. Treatment causes more harm than good. Well, hard to have more harm than death, right? And so being that prostate cancer is the second leading cause of death, how much harm can you have compared to death? That's like these people saying they don't want the COVID vaccine because they might get a flu. You know what I mean? So what are the risks of treating it? The risks are erectile dysfunction and 40-50%, and incontinence. Don't we have great treatments for ED? Yes. What's the rate of ED in these men in this age group anyway? 1 in 3. So you know what I mean? You can't lose what you don't have. But incontinence, this is something that's treated, but not at the risk of people losing their lives. It is also true that too many men have been treated unnecessarily, just like tonsillectomies and hysterectomies. We have overtreated prostate cancer. But now we know that there is criteria well established for those men who not only could, but should be on active surveillance. And that's at least 25% of the men. So next slide, I think that might be it. So, bottom line, I hope that I've demonstrated how PSA screening could be effective if used appropriately with smart screening and using our biomarkers. And we were on a nice little ride. But unfortunately, since the U.S. Preventive Task Force recommendation, we really are we're going backwards. And my great partner, Dr. Lannis Hall will take it from here and further explain why we need your help.
Thank you, Arnold. I'm going to try to share my slides. That was great, particularly your comparison to vaccines in regard to just making a reasonable decision. I want to be clear that we do follow the guidelines of the American Cancer Society, and that Dr. Bullock is one of the founders of the Prostate Cancer Coalition. And the American Cancer Society is actually a partner with the Prostate Cancer Coalition. So let's see if I can share my screen. Can you see my screen?
Not yet, Dr. Hall.
Not yet? All right, let me try again. How about now?
Now we see the lovely mountains there. Yes.
Okay, good. I want to make sure I have the right presentation up here. Okay. Can you see it? Is it okay?
We sure can.
Okay, great. Well, I want to thank Brandon and Kiko and Mia and the MQF for inviting us to talk about an incredibly important health topic. As Dr. Bullock stated, it is the second leading cause of cancer death, and 1 out of 7 African-American men will be diagnosed, and 1 out of 25 African-American men will die of the disease. And this is compared to 1 out of 9 and 1 out of 40. So what has happened to the screening rates? Even though in 2017, the US Preventive Services Task Force course corrected and gave a narrow indication for informed decision-making for men between the ages of 55 to 69. The damage had been done, and I'd like to show you in 3 different data sets what has happened to screening rates since the 2012 initial guideline that recommended no further screening for any man. If you look between the years 2010 to 2018, you can see that there's a 20% reduction in the percent of men who responded to a survey that is national by our Behavioral Risk Factor and Surveillance System, responded affirmatively that they had had a PSA screening. So that's a drop to 33%, so about 1/3 of age-eligible men screening. And let's look at a different survey, the National Health Interview Survey, which is also a national survey, that indicated that African-American men who are age eligible over the years of 50 in 2015, only 31%, as compared to 37% white men, responded that they had had a screening in the last 2 years. And surveys are just that, and they have a tendency to possibly inflate the actual screening rate. And so using the electronic health chart is another way of determining what are the actual screenings that are done, because you can then take ICD-9 codes and look and see how many screenings were done for age-eligible men. So this was a large primary care practice in Cleveland, the Cleveland Clinic, with over 160,000 patients, in which 90% of the PSAs are ordered by primary practices. And they use the electronic chart to see just how many PSA screenings have been performed since the guidelines were issued to no longer screen. And what we find, regardless of age group, you all can easily see that either in 40 to 49, 50 to 69, or 70, screening rates have dropped from 2007 to 2014. Even in the age group that's now recommended to have informed decision-making, 55 to 69, the screening rate has dropped to 25%, and even lower for 40 to 49 and above 70. And what about men that we consider high risk? And those are men with a family history of prostate cancer, where we know their incidence is higher and they are at a higher rate of possibly having a BRCA1 or 2 mutation. Screening rates also dropped, so that there was no differentiation in the primary care practice between average risk and high risk. So in 2014, the screening rate had dropped to 20%. And then what about African American men compared to non-African American men over this same period of time? Screening rates are now down to 5% of men ages 40 to 49, where the American Cancer Society recommends you have that initial PSA. I want to just say this again, 5%. So screening rates have dropped significantly. They were never what they should have been. If you compare screening rates to mammography screening, which is over 70% in Black and white women, or screening for colon cancer with colonoscopies, which is above 60%, this is an easier screening tool, but yet we have less adoption, and it really is due to the controversy around PSA screening. So if the screening rates have dropped, and Dr. Bullock made it clear that in the pre-PSA era, many men, over 50%, were diagnosed with advanced and metastatic disease, let's look at what has happened with the incidence rates by stage of disease. If we look at ages 50 to 74 years, there has been a decrease of 7.5% annually. So an annual decrease in the incidence rate of localized disease. There is an annual decrease of 5.3% in regional disease. And there is an increase of 1.4% annually in the diagnosis of metastatic disease. So just what we feared. And the real concern is that the CDC just this year said, hey, in early 2000, the metastatic rate, or the incidence of metastatic disease, was about 4% in the population, and it has doubled. It is now 8% of the newly diagnosed cases. So just what we feared. As you know, if you don't screen with PSA, there are no early signs and symptoms of prostate cancer. So you won't know that there is a fire down in the basement until it gets upstairs. And because you don't know that, this is why we know that screening for localized and regional disease is so important, because these are disease states that are curable with the treatments that we have, whereas metastatic disease is not curable. It is manageable, and we have excellent treatments, but it's not curable. So just like we found with COVID, that in our vulnerable communities, COVID disproportionately affected survival of our men and women, we see the same with regard to county poverty level and the incidence of metastatic disease. And so if we just look at these bar graphs, you can see that in counties that had households where only 5% or less were below the federal poverty level, there was hardly any metastatic disease in men less than 50 years of age, and 9.2 per 100,000 in men 50 to 74. Compare that to households in counties where 20% or more were below the federal poverty line. We see a much higher rate, almost double. So just like we see with other disease states, poverty level and other social determinants of health play an important role in prostate cancer and the incidence of metastatic disease, because access to care and quality care is also factored in. We asked our St. Louis County Health Department in 2019 to perform their first cancer profile. And we worked with them to look at our incidence rates and mortality rates by neighborhood poverty level. And if you look at our prostate, at our neighborhood poverty level, and look at the incidence, which is right here in the mortality, in low neighborhood poverty, so in the more affluent neighborhoods, the incidence was about 116 per 100,000, and the mortality rate was 13.4. Now compare that to very high poverty, very similar to what we were seeing on the previous slide. You have a almost three times higher incidence rate and almost 3 times higher mortality rate. So 40.8 versus 13.4. So incidence and mortality are also are also increased in neighborhoods where poverty and access to care are very narrow and small in terms of the accessibility of patients to receive timely care. So we see in our largest and most populous county in the state of Missouri is that Black men have a 2.4 times greater mortality rate than white men. And I just skipped that slide because it's really demonstrated here. So the percent uninsured in St. Louis County is right here and greatest in this neighborhood, which exactly overlays our mortality rate for prostate cancer, where it is most significant. And this also overlays where we have our highest neighborhood poverty levels. So this just talks about the importance of social determinants of health, which we've heard over again as it relates to outcomes with COVID. And we see multiple disease states that the outcome is influenced by social determinants of health. So where you're born, where you work, your education level, your income, your access to quality care, as well as your insurance status. So this gets to what kind of treatments are delivered across the United States, and are they equitable? So our racial variation in receipt of quality radiation therapy was evaluated over a 2-year time period with over 3,000 men in the United States. And Dr. Moses and his group noted that Latinos were less likely to receive quality radiation therapy, and that African Americans were less likely to receive the recommended dose of radiation for the stage of disease, the correct fields, and more likely to receive radiation at low quality radiation oncology centers. We have some similar studies in surgery as well as other disease sites. So this is not specific to radiation. And I would just point out that men who presented with high-risk prostate cancer, those are prostate cancers that there is no confusion and disagreement that these men should be treated. They were 38% less likely, African-American men were, to receive treatment than white men. And even more confusing is that as the stage became more aggressive from low, intermediate, and high, the likelihood of receiving treatment actually went up. So this gets me finally to our prostate cancer mortality evaluated by equal access healthcare systems and standardized treatment. And so what is this forest plot that I'm showing you? Well, we know that there are disparities in the delivery of care, because I just showed you one of many papers that are out there. And we know that there are other socioeconomic factors that impact, patient outcomes. And we talked about that, neighborhood poverty level. So several groups of researchers compiled their data to offer prostate cancer outcomes by race. And so this is the largest data set that has ever tried to do this. And so there are 3 different data sets here. And the first one is the Seer Data Set, which is a population data set of 18 different tumor registries across the United States. And in this data set, Black men had a higher prostate cancer specific mortality compared to white men, which is consistent with what we've been telling you. And that rate remained higher despite trying to adjust for stage and PSA and even out the patient population. Compare this to the VA. So the VA, these are 4 VA health centers across the United States. And all of these men had radical prostatectomy, so curative treatment for non-metastatic disease. But they have equal access because they're in a VA. They don't have to worry about insurance. They have a primary care. They have access to the same cancer physicians and urologists. Black men actually had a slightly lower risk, though not statistically significant, of the mortality rate compared to white men. So there was no difference in outcome in the VA data set. And this is 4 VA hospitals in several areas, Georgia, California, and North Carolina. And finally, we get to randomized controlled trials. And we often hear that we don't have enough African Americans participating in randomized controlled trials, and Dr. Bullock showed that earlier. This is the exception to the rule. Radiation therapy oncology group studies have always been able to accrue adequate numbers of African American men and women to their studies, and this is no different. These are 4 different radiation studies that were compiled, and about 20% of the cohort is African American. And when these treatments are given in a standardized fashion, so there was no difference in the delivery of radiation in this study, there was the same staging workup and the same follow-up for Black men and white men. There was no difference in outcomes. So when treatment was delivered equally, the outcome was no different. And in fact, in this forest plot, there was a statistically significant improvement for African American men compared to white men, meaning they had a survival advantage. And this is one of the few randomized trials that have ever shown African American men or women doing better than white men or women. But this brings home the point that if we can provide equal access and quality guideline-directed care, then it is not the biology of the disease that is dictating outcomes. Right now, across the United States, it is social economic status. It's whether you have insurance. It's whether you can receive quality care. So prostate cancer treatment outcomes are significant, but are due to social determinants of health and not biology. In the last 25 years, improved screening and treatment has reduced mortality in African American men by 50%. And PSA screening rates are falling, and metastatic disease is rising. And that's threatening all the gains that we have made over the last 4 decades. And so we really need legislation to improve access to care and equity and healthcare delivery for prostate cancer, similar to what we have for the National Breast and Cervical Early Detection Program. And I will leave it there. So thank you so much for allowing both of us to present that data.
And it was truly compelling, Dr. Hall. Thank you both to you and to Dr. Bullock for giving us some things. And you gave us so much, and I really want to, in these last 18 minutes or so, break down some of what you mentioned, right? So Dr. Bullock, you came and you presented to us, the significant, amongst many things, the significance of screening and really especially the role of USPSTF in all of this, right? So, if you were to really capture all that you were discussing in terms of the long-term impact of the USPSTF screening criteria or recommendations, particularly for prostate cancer, and you also alluded to this a bit, Dr. Hall, what is the long-term impact? And is it just because of the recommendations? Is it more complex because of what men especially are receiving from their primary care physicians? What's the mix, if you will? And how do we navigate a more effective prostate cancer program, particularly for those who are at high risk?
So, the problem is that In addition to Lannis and myself, we have this Prostate Cancer Coalition of volunteers and other health professionals and survivors who go out to churches on a regular basis and men's groups to talk about the benefit of PSA screening. But even if we went to the largest churches and screened 200 people every Saturday, that would pale in comparison to the 200 people seen today in a very large medical practice who should get screened. So we're just touching the tip of the iceberg. And so now that 10 years ago, you had primary physicians telling their patients, you don't need a PSA. The PSA is not useful. It's very hard to get these, primary care physicians to get back online with strongly recommending prostate cancer screening, even to the most high-risk communities, such as the one I'm in right now.
One of the things that we have attempted to do, and I know that others are doing, because there's so many people in this space advocating for PSA screening, is to decouple PSA as a diagnosis and automatically requiring treatment. PSA is just looking at the health of the prostate gland. It should hardly ever be the only test that you do before you directly go to a biopsy. At this point, there's so many additional biomarkers that can be done and imaging that we can reduce some of the concerns that many primary care doctors had about unnecessary biopsies and treating what we call clinically insignificant prostate cancer. We have really moved beyond that, and we have a new paradigm in how we manage active surveillance, in how we put men on active surveillance and who are candidates for active surveillance. I will also say that we've learned that the gold is really in changing the minds and the attitudes of your primary care physicians. As Dr. Bullock said, you can go to churches all day, but even if you talk to 1,000 people, if they go to their doctor and their doctor says, you really don't need it, it's hard for that patient to be able to come back with a rebuttal other than to say, just do it. So you really have to present this data, and many primary care physicians have no idea how flawed the PLCL study was, and that the arm that was supposed to be essentially usual care control group had 85% contamination with men getting PSAs. So there was no way you were going to see a difference. Yeah. And then worse, African-American men were not included at rates where you could do a subpopulation analysis, which our legislation has been for 20 years, has stated that you must be able to have diverse representation in clinical trials so that you can make sure that your outcomes are applicable to all your subgroups. That did not happen. And the fact that the high-risk men, the incidence rate and the mortality rate for African-American men are so much higher, and they were not represented, but then included in the guidelines, is a tragedy. It's an injustice.
It truly is an injustice, and I thought that your map was so compelling, where you overlaid the role of socioeconomic status and the prevalence of disease, and specifically here, I think you were showing insurance status as well.
Yeah, all of it.
Mm-hmm. And you can do that really with pretty much any ongoing acute or chronic condition, right? Certainly right. With COVID, right? And so how when you're talking about really moving legislators, but then also, to your point about moving providers, what are the maps that you show them that really, get them thinking again, like, okay, perhaps I do need to rethink the role of this particular study, or I do need to listen to my patients if they come in requesting a PSA. And then I do want to talk a little bit about fear, because that's yeah.
I want Arnold to chime in on this, but we rarely see a 5-year cancer-specific survival that's 100%. And you see that in localized and regional prostate cancer, regardless of race, white or Black, if they are treated and treated with guideline-directed care. Now, let's get to metastatic disease. The 5-year survival is 30%, and that has really been no different for the last 30 years. You don't cure metastatic disease. So I think one of the compelling arguments is when you give the statistics in terms of the incidence and the metastatic rate in Africa.
We lost you a bit there, Dr. Hall. It sounded like you were saying.
They don't know that. They don't know that the mortality rate is 2.4 times or 140% higher. And so part of this is just bringing the data home to them, because this is a disease that has a wide biologic variability. Yes, we can talk about, in one hand, managing prostate cancer and not treating it at all. But then in the other hand, saying it's the second leading cause of cancer death. That's a wide biologic variability. So I think part of it is educating our primary care physicians to prostate cancer incidence, the difference and disparity in African-American men, but that there are also other options outside of going directly to a biopsy and treatment.
So one of the things that we are doing is trying to educate, our colleagues, and by simple things, but we're also trying to educate the community. So we put up billboards, especially in high-risk communities. We send out a little postcard, really brief postcard. We know doctor's going to throw it away after looking at it for 30 seconds. So every month or so, we try to get a little blip about trying to keep PSA and prostate cancer in the minds of our colleagues. But little simple measures, little postcards. So.
But I do think it requires legislation. When you think about breast cancer and what we call the National Breast and Cervical Early Detection Program, it is a safety net for uninsured and underinsured women who are age eligible and income eligible to receive a mammogram if they can't afford it or they're uninsured. And they are also enrolled on Medicaid if they are diagnosed with breast cancer. We have nothing similar for prostate cancer. So even if a gentleman goes out and goes to a free PSA event, how are you going to get the biopsy? What if you need other staging? We really have to think about how do we support men with a disease that's highly curable, and it's clear that the treatments work if you can get a guideline directed care in a timely fashion.
Yes.
In time.
So part of the problem is we're able to go to some of our financially fortunate patients in order to generate funds for our billboards and for our brochures and postcards. We get some funding through the Siteman Cancer Center and other support here locally. But we're in St. Louis. I'm sure they have such through Isaac Powell in Detroit and other groups around the country. But what happens to the smaller communities? What happens to the smaller communities where you don't have the African-American face of prostate cancer out there beating the bushes? And so I agree with Lannis that, we need a national campaign to get this to the masses.
Well, let's actually talk about that a bit, Dr. Bullock, because we actually have, at least at this age, an ad hoc, not so much campaign, but something that moved people in a way that we didn't anticipate. The death of the Black Panther. When Chadwick Boseman died, it woke a lot of people up to prostate cancer. And this man was not within the age limits that the USPSTF is saying one should have a prostate screening, right? He was he was just over 40. I think he had
he had colon cancer, but you're right. He was even under the screening age.
He was under the screening age, yeah.
And actually following what has been shown over the last few years, which is a higher incidence of younger people under what is even our screening guidelines, developing colon and rectal cancer and having very aggressive disease.
Yes.
So yes, it helps to have someone that you can relate to really bring home that this can happen to you.
Yeah.
And with prostate cancer being so common in white men and African-American men, we actually have many men who have gone out and told their story. we just have to move it to legislation.
That's exactly it. So what for you has been the bridge? I mean, so I used to, prior to working with the American Medical Association, I worked on the Hill, and I worked for a member who ran the Congressional Black Caucus Health Brain Trust. So we had all kinds of people coming in to talk to us about every single thing under the sun with respect to health. And many of those people are actually on the call today. And one of the things that I always took away as the staffer who handled the health portfolio is the numbers were significant, but it was the stories that moved hearts and minds, right? And so we have to lead with the stories. And to your point about that face, hey Val, that, you know, having that face is important. Exactly. So what do we do now, especially because policymakers are so inundated with COVID related work. So a lot of times, you know, issues within that become prevalent within legislation are issues of the moment. How do we keep the story of prostate cancer alive for our legislators who are fighting this fight and who can pick up the mantle?
We would love to come in. You know, we have one of the largest prostate cancer support groups in the country here in St. Louis called the Empowerment Network. And we've tried, especially during the Bullock era, to try to get them to turn the lights at the White House blue during the month of September, you know, prostate cancer month, and have on national news, why are the lights at the White House blue? Something simple as that, right? That's free advertising. We weren't able to affect it, but you know, we have had some major people in the community who've had prostate cancer. We had King Griffey join us here in St. Louis 2 years ago. King Griffey Sr. Let me make sure we got that.
Senior, right, exactly.
And you know, and Sidney Poitier did a video shoot with our other colleague urologist James Bennett in Atlanta one time. So we have notable people who've had prostate cancer, but there's no money behind prostate cancer to make it happen.
I think this is a good start, and I suggest, you know, Finn does a great job, Thomas Farrington, and we all just have to continue to push. I believe that part of this is straight injustice, and the fact that African American men, and these are young men suffering, these are people in a community where you're losing fathers and grandfathers and uncles and people who really are being taken away from the clutches of, taken away with this disease too early. And we've got to tell more of these stories. And most importantly is this data that I just presented that's out there in this space now saying that, hey, it's not the biology. It's not like we don't understand the treatments work. And that's a huge turn, Mia, when you get to the point where you say the treatments are effective. We just have to give the proper treatment, that it is not like you give a treatment and the outcomes are still poor. That's not the case. So we have even more compelling data for doing something when we now show that across multiple different studies, not even just clinical trials, but in the VA system, you can get equivalent outcomes. So that's very different, and it's a big push. It's hard not to act when you know your treatments are effective.
You're making such a good point there, Dr. Hall. It truly is egregious to reach a point where you're like, listen, this works. Take this. You know, it's not a magic elixir. It's not a potion. And you know, it's just a matter often of political will and then also individual decision. Now, we've been having the conversation about social determinants of health, and we need to keep the conversation at that level. It has to be a structural conversation, but there are individual things that we also need to overcome. And so in these last couple of minutes, I want to just talk a little bit about fear and stigma, right? So the PSA, right? When we're talking about a prostate exam, it's a very different type of exam today than it was 15, 20 years ago. Can you walk our audience through that? And then also, if you can just briefly speak to the role of women in men's lives with respect to raising awareness and pushing the men to do what they should do.
So even though we really pushed the DRE 25 years ago, most people admit that most men who see a physician and are screened for prostate cancer are screened by PSA alone. And we're more than happy to take PSA alone because the majority of men diagnosed with prostate cancer have an elevated PSA. So based on studies, you might lose up to 15% of the men who have a rectal exam only detected prostate cancer. And so eventually the majority of those men would be picked up before their cancer becomes advanced or beyond treatment. So, so the fear of being diagnosed with prostate cancer probably relates back going 30, 40 years ago, when men who had prostate cancer, it typically had already gone to their bones, right? 2/3 of African-American men had cancer that was spread. So in the 70s and 80s, if you had prostate cancer spread to your bones, how were you treated? You had your testicles cut off. And so if you knew that great Uncle Joe had his testicles cut off from prostate cancer, and everybody in the family knew that, what's your chance of telling everybody you had prostate cancer now? Probably unlikely, because they're saying, oh, now cousin Eric got his testicles cut off, right? And so, but that's historic. We don't do that anymore. But yet and still, some of these historic significances, there's a reason why some fears exist. That might be a barrier to treatment.
And I think women are absolutely critical to the health of their families, the health of their fathers, their brothers, their husbands, and their sons. And that is no different for prostate cancer, which is why maybe one of the strategies is to really have leadership for women in this disease state, pushing it like women do for breast cancer. I can't tell you how breast cancer advocacy really does pave the way for what many other disease sites do. And women are willing to tell their stories, share their stories, advocate for each other. And men, as Dr. Bullock said, are very shy about telling stories about prostate cancer treatment because of the stigma about, well, does that mean that there's erectile dysfunction going on? Or does that mean that you're still a man after they've removed your prostate gland? So we really have to, part of this is education, but part of it is having women and men, survivors, come out strong and show the importance of screening. Just like we've learned that with vaccinations for COVID, we really have to do a PSA campaign and get everyone out there, people of influence, talking about the importance of screening. And we have noted, right, that from the beginning to now, screening rates and acceptability and vaccine hesitancy has gone down, and vaccination rates are beginning to go up. So I think we have to do the same thing with prostate cancer, where we know there's a lot of hesitancy to screen. And quite frankly, there's a lot of distrust in the medical community. And we have to recognize that and talk about the importance of what we just showed. You can go to a poor quality center and not be treated right.
Dr. Hall, Dr. Bullock, the both of you just brought so much. I wish we had another session where we can unpack. There's so much that we can unpack. I will say, just from a personal perspective, my stepfather is a prostate cancer survivor. Just last year, he completed his rounds of radiation, and thank God he's with us today. He's well. And we've had very candid conversations about parts of him that I'd never wanted to talk about, but we did, right? And the family has. And I think that that's exactly the level that we need to be at, not just within our self conversations and between intimate relationships, but certainly amongst the family and by extension to policymakers and for sure to primary care physicians. So I thank you both for bringing your insights here today. We thank the Siteman Cancer Center for allowing us to borrow your hour and an hour of your time this afternoon. And we look forward to future conversations, and thank you for the work that you're doing.
Thank you for the work that you're doing.
Thank you for having us. This is how we get started, right? This is how we move forward. Thank you.
That's right, for sure. And I'll hand it off to Brandon Garrett to give us a close.
Yeah, no, I don't have much to say, but the most important words ever, thank you. And we really do appreciate you educating and enlightening our audience. Our audience tends to be educators themselves, so you educate the educators and help them to get the word out and educate their communities. At the end of last month, of Women's History Month, we got to do a bit of focus on women's health. And so it's good to also focus on men's health here as well.
And today in April is Minority Health Month too. So let's make sure, for all of those on the call are doing what you need to do. Go see your PCP and talk to your families too.
I would like to say there are 2 questions in the chat. If we don't have time, if we can just get their emails, we will respond to both of them.
All right.
And also,
Okay.
I'd like to say thank you to Ms. Purnell and to Brandon for all the work that you've done to make this happen. We appreciate it.
Absolutely. Thank you so much, Mia and Brandon, for inviting us. This was great.
All right. Thank you, guys. I hope everybody has a good weekend, and we see you next weekend, next Friday as well, and then for our summit coming up at the end of the month. And so with that, I'll let everyone go for the day.
Yes.
Thank you. Bye-bye.
All right, bye.